So thank you all for sticking around, and we have still over 50 people online, which is great. Actually, it's going up. So thank you for all for participating in this last session. As I mentioned, the focus is on critical values, which is really important, not just in chemistry, but in several areas of lab medicine. So we're going to hear some of the work that's been done in this area. Dr. Elaine Goh is going to start, then we'll have a presentation by Dr. Felix Leung. Dr. Yip will then coordinate the questions. Now, the question and answer session. So Dr. Goh is actually based at Trillium. She's a medical geneticist and interim division head for clinical genetics at Trillium Health Partners. She's also an assistant professor in LMP, has been very active in this area. Actually, she's been quite productive. One of the first Quality Council members to actually get a lot of her survey done, and a lot of the manuscript that was then put together. Her manuscript on this project has actually just been accepted for publication and will be coming out shortly. She has a lot more on her CV, but I'll just leave it at that. And welcome, Elaine. Please, if you're ready, please go ahead.
Thank you so much. And thank you so much for the opportunity to present today to this exciting workshop. And thank you for the introduction. I'm going to move my slides now. There we go. And so as Dr. Adeli said, we're happy to announce that it has been accepted for publication as a part of the Journal of Applied Laboratory Medicine as a focus report. And I thank very much the collaboration and efforts along with Dr. Jim Staropoulos and Dr. Adeli as part of this, as well as also the Quality Council, who has provided valuable feedback in this particular survey. And so in terms of background, when we think about genetics, oftentimes we think about things like chromosomes and molecular tests, but perhaps not so much about critical values. So as a definition by Ludenberg in 1972, this person mentioned that a critical value represents a pathophysiologic state at such variance with normal as to be life-threatening unless something is done promptly or for which some corrective action could be taken. And so from the point of view of genes, oftentimes you don't think that there may be a corrective action per se. So perhaps this may be why critical values have taken a little bit of a backseat in terms of genetics. There's also been a survey done of 92 United States medical institutions in 1990, trying to define quantitative and qualitative values. And if you look at that particular survey, I was trying to sort of extract what would be considered genetics or metabolic type of investigations that could be considered critical. And only 5% of these 92 laboratories that were responding mentioned lactic acid, which is one type of thing that I think about when we're talking about metabolics, but maybe not necessarily genetics. And then from a qualitative perspective, the idea that the blood smears may show sickle cell would also be considered a critical value. So it starts to get at the idea that there may be some things, but there is certainly a paucity within the literature about critical values in genetics. And it's this gap that we wanted to try and fill as part of our survey. And so when we think about this critical values survey done through the various different laboratories in Ontario, if we were to just focus on GTA, there would probably be only a few laboratories. And so we actually extended it out across to all of the genetic laboratories that we're aware of in Ontario. And so there were 11 different sites for which Dr. Staropoulos and myself had emailed the various different genetic laboratory directors. And we sent to them an online survey of about 11 questions via email through SurveyMonkey, and then asked for their response. Of course, amateur move on my part for survey writing that we sent it out in July of 2019 because it was during the summer months. And so we had to resend it out when it wasn't the summer so that people actually had a chance to respond and weren't away on vacation. And so between July 2019 and September till October of 2019, we were able to get our respondents. And so in terms of the questions that were asked, we were really interested in thinking about critical results, not just for genetics in general, but more specifically in the various different areas. And so when we think about genetics, oftentimes we're thinking about cytogenetics, where we're thinking about karyotype and microarray analysis, FISH studies, versus molecular genetics, where there might be a cystic fibrosis result for a CFTR, or there might be some other forms like exome sequencing. So that would be part of molecular genetics. And then there's also the other aspects too. So I had mentioned metabolics. So metabolic genetics or biochemical genetics would include things like acyl-carnitine profiles, plasma amino acids, lactic acid, ammonia, etc. And then also the idea of maternal marker screening. And that refers to more the idea of enhanced first trimester screen and the previously tested and integrated prenatal screen. So those would be encompassed as part of maternal marker screening. So we think about all of those different aspects as part of genetics. And in addition to asking what those critical values and reports might be, we also asked about what the reporting process could potentially be, with the idea that if there is something critical, that the reporting process may be, in fact, a little bit different. So what might that look like? Is it more the idea of this is what we would do on a routine basis versus what we would do on a more critical value basis? And so we asked those questions as well. In terms of the question type, we wanted to make it a little bit more broad because these were the ones that we were thinking of, but we wanted to have the ability for other laboratories to be able to provide alternative responses. And so most of them were a select all that apply rather than a ranking. And we'll talk a little bit about limitations in a moment with this type of question versus a ranking sort of question. Finally, in terms of ethics, when you think about ethics in this type of survey, it wouldn't necessarily identify the lab in particular, and it wasn't required because it was a quality improvement initiative. So when we looked at critical values in regards to genetics, our response rate for our survey was 9 out of 11. Laboratories did respond to us. So it's quite a good and robust number at 82%. And we recognize that in terms of the different services that the laboratories had provided, 7 out of 9 of them provided cytogenetic services, and 7 out of 9 also provided molecular genetic services. Only 3 centers provided testing for things like acyl-carnitine, plasma amino acids, etc. And then only 1 center reported back that they were reporting on maternal marker serum screening. And so for the majority of the rest of the results, I'm not going to talk about them the maternal marker screening part, but focus mostly on cytogenetics and the molecular genetics. And what we found too was that in addition to kind of thinking about the results themselves, that actually there was an idea of a critical patient type. So when we're thinking about critical results for troponin, for instance, I don't know necessarily if I would be thinking about a patient type or where they're from, but in genetics, we differentiate partly because of the timing of these results. Oftentimes, a lot of our results take about 3 to 4 months to come back. And so if you think about within a prenatal time frame or a newborn, oftentimes this information would be ideally gathered prior to the 3 to 4 months. And so when we think about critical patient types, where perhaps they need a different type of reporting process, about 78% had mentioned that if the case was considered prenatal, so as part of an ongoing pregnancy, that they would consider expediting or reporting the process a little bit differently. Or for instance, like a lot of our oncology colleagues, if they were trying to expedite the information because they were actually going to decide whether or not to take out the full colon or take out ovaries, for instance, then we're honoring the fact that the ordering physician would be wanting this information sooner to make treatment decisions. And then in a newborn period, oftentimes the types of newborns we're seeing are in the NICU, for instance, when they're first born. So oftentimes it's nice to know what's going on very early on so that we can make decisions about management. And so the patient type became quite important in terms of thinking about the reporting process. And then in terms of biochemical and metabolic genetics, which is sort of more where I think about critical values, in this case, 2 out of 9 had mentioned venous blood gas and ammonia, and 1 out of 9 had mentioned lactate. But recognize that we're talking about the 9 different sites, but only 3 of them really provided biochemical and metabolic services. So theoretically, 66% mentioned that venous blood gas and ammonia within biochemical centers were considered urgent. Having said that, I know that even if you don't do biochemical and metabolic genetics, that, for instance, Trillium Health Partners, we run lactic acid, we run venous blood gas and ammonia as well. So perhaps taking that into account, only about 22% had mentioned that this was a critical result. Now, if we were to move specifically to the different areas, so I mentioned that I wanted to highlight specifically cytogenetics and molecular genetics. This is the graph that I'm showing you that provides information about the various different options that we had provided for them. And so on the y-axis, what you see are the various different options that we had offered to the different laboratories as part of the survey. And there was an other there so that people can actually add on that information. And then on the x-axis, you see that there is a percentages. So the percentage of the 9 different respondents, what is the percentage of those laboratories that had reported, for instance, an abnormal QF-PCR result, looking at trisomy 13, so 3 copies of 13, trisomy 18, trisomy 21, or triploidy, which is 3 copies of all of the chromosomes in a prenatal setting. So not surprisingly, the majority of laboratories did feel that those particular types of results would be considered critical or require some type of different reporting process. So abnormal prenatal microarray, so looking at all the chromosomes in fine detail for so-called microdeletions or missing pieces of the chromosomes, or microduplications, extra pieces of the chromosomes. And then P and LP refer to the fact that those are labeled as considered so-called pathogenic or disease-causing. So P is pathogenic and LP is likely pathogenic, as mentioned down below. And so it wasn't really as much of a surprise to me, at least when I work in this field, that these 2 areas, when we think about prenatal, would be ranked very highly in terms of being considered critical cytogenetics responses. Having said that, however, when I look at the very top one, I was quite surprised, but pleasantly so, I guess, about the idea that the abnormal prenatal microarrays that were considered so-called VUSs, and I'll mention that in a moment, but susceptibility loci were actually the highest in terms of requiring a different reporting process. And in my mind, I'm thinking perhaps it's partly because there's some discussion that's involved with this type of result. So a VUS is a variant of unknown significance, as mentioned down below. So it's a change, but we don't know exactly whether this change is considered disease-causing or not. And then when we talked about a susceptibility locus, what we're talking about is a particular area within the chromosomes where there's been some evidence to show that there's an increased risk of. So that increased risk of may be increased risk of autism, or an increased risk of intellectual disability, or an increased risk of neuropsychiatric conditions like schizophrenia and others. And so it was kind of interesting to see that that actually floated up as the top as being the one that would be the highest rated amongst the various different laboratories. And of course, these ones a little bit below tend to be more of the postnatal ones, so not necessarily within a pregnancy, but a little bit later once a child is born. Now, when we look at the others, the laboratories have mentioned things like oncology. So certainly within oncology, when we look at the chromosomes, some of that allows us to prognosticate or tell us what the chance of a treatment being successful is or not, or what the possible natural course of the condition is. So oncology, bone marrow transplant type of monitoring, as well as FISH for aneuploidy and pregnant family members, all were considered part of this other group. And so it speaks again to the idea of the patient type as opposed to the patient result. So similarly, when we flip to the idea of molecular genetics testing, similarly, we see sort of pathogenic and likely pathogenic results in a prenatal setting, of course, would be high. But again, we're seeing this theme of unexpected results. So it was fascinating that, for instance, I had an individual who was getting tested for Fragile X syndrome, which is on the X chromosome. And within the molecular report, they had told me that this person also has Klinefelter syndrome, which is 2 copies of chromosome X and a copy of chromosome Y. And remember, we didn't do this test because we were looking for cytogenetics. We weren't looking at the chromosomes, but because we were looking at the X chromosome, because this FMR1 gene is on the X chromosome, they actually saw 2 signals of the FMR1 gene within this male individual. And so it prompted us to understand that this person also had Klinefelter syndrome. So again, in these cases where it's an unexpected result, I would imagine that the laboratory director would feel that this is something that needs to be communicated more than just as part of a written report. And also indeterminate results, for instance, are here. And maybe not surprisingly, when when I work in genetics, but maybe for others, suspected non-paternity and non-maternity are also issues that come up as a part of testing that one may not tend to think about when we're doing lactic acid testing or ammonia, for instance. So those are the types of results, again, that were thought to be more likely to be critical and or requiring a different type of reporting process. And so the others in here, again, were the prenatal results, bone marrow transplantation monitoring, oncology, and pregnant family members. And so when you're thinking about these critical results, we then need to think, well, if you have a critical result in front of you as a laboratory person, how are you going to convey this message? How are you going to get it across? And so from the point of view of reporting, we then looked at the idea of what the reporting process is and whether it changes based on whether there is a critical result or not. And so the first panel that you see on your left-hand side here is about what is done when there's an insufficient or incorrectly collected sample. So I'd imagine that perhaps this is probably most relatable for all the various different areas within laboratory medicine, the idea that you can't get a result if it's insufficient in terms of the amount that you got, or perhaps a label isn't correctly sort of placed in such a way that you are confident that the result you are going to report on is for that person. And so in my mind, it's also another critical result, so to speak, because then you wouldn't have a result if it's not sufficient for you to actually run the test. And so when you look across the board, again, the 9 different respondents here, this was a please select all that applies. And so it wasn't a ranking. It wasn't like they do this first and then they do this. So they might do a few things together. And so if you look here, they would enter the finding in the health information system. And in Trillium Health Partners, we now have Epic, so we'd be putting it into Epic. But then the fax the report would be a little bit higher than just mailing the ordering physician. And as I mentioned to you, in genetics, oftentimes our tests don't turn around within like an hour or half a day. It's usually quite a bit of time. And so we wouldn't think anything of a result not coming back in 3 to 4 months unless we're sort of following up closely. And if we find out that in fact they couldn't run the test to begin with, that's about 3 or 4 months time that's lost in terms of getting the results to the patient. And so that's an interesting point, again, raised from a genetics perspective. And sometimes people would email the ordering physician, or sometimes they would call the physician via telephone. In terms of this other here, they mentioned whether it's one of those irretrievable samples or whether it's something that they can do something about, and then they would call the physician based on that. So that's the idea of insufficient and incorrectly collected samples or incorrectly labeled samples. And then if you think about the panel on the right-hand side, now you see the comparison of reporting for critical results versus routine results. So for critical results, I put it into red, and for the routine results, I put it into blue. And if you were to look at, again, the same options that are available, the fax the result, enter into health information systems, etc., what you see is that normally in a routine case, you would see that they enter into the system and they may mail the ordering physician. But when you start to shift to the idea of critical results, what you see is different. And again, I can't do any statistics about p-values and such because the numbers are so low. But if you look, for instance, calling out the result via telephone is a lot higher in magnitude than a routine result, or emailing the physician is a lot higher. And faxing also is a lot higher, whereas if you are having a critical result, you'd less likely mail the ordering physician that, nor would you necessarily as highly put it into Epic, although again, you would put it into your medical record system, but you'd probably do some of the other things as well with it. And so this gives you sort of a graphical representation of what would be different if we were to find a critical result in genetics. And so if you were to think about the study in total and think about some of the discussion points, the first is that this is the first study looking at Ontario genetic laboratories to ask that question about critical values within genetics, partly because there is a gap in the literature, that there is the current paucity of literature related to critical results within genetics. And then again, going back to our definition of things that are potentially life-threatening and where a corrective action may take place, perhaps that's a little bit more applicable to various different patient types, such as prenatal and the oncological setting in the cancer setting. There was one comment that was made by one of the centers that says relatively few laboratory values are actually considered critical, and there's no biochemical genetic test results that meet that definition. So it's kind of interesting, again, to put it in light of what you've probably heard today, that genetics perhaps is a specialty where the results take a longer time. So we kind of expect that things take longer, but perhaps the idea of critical is a little bit different than, say, a critical troponin, for instance. Regardless of that, though, we still need to think about the methods in which they are being communicated, and it needs to be communicated in an expedited fashion. And so I'd mentioned briefly as part of the methods a little bit in terms of limitations. And so we recognize that part of it is in the way that we had asked the questions. So when we start to ask, please select all that apply, we're not able to actually get a ranking as to what you would do first, what you would do second. Because what we wanted to do was make sure that there was inclusivity about the various different types of results that one would need to report on or want to report on. And of course, the idea of cancer and other such things weren't as prominently displayed within our survey questions, but they did come out as part of the various different comments that were made of the various centers. We do recognize, and this was a great point by the reviewer for the paper, that we didn't ask about cytogenetic analysis failure, but we did ask about failure and insufficient results in general. And we didn't ask about prenatally detected carrier status. So for instance, if there is a pregnancy that is a carrier for BRCA1 and could potentially have a risk for an adult onset condition or pass on a particular condition because it's an autosomal recessive condition, we didn't specifically ask about that. So it wasn't looked into. And we certainly didn't ask about prenatal detected adult onset conditions. So apologies, the idea of BRCA1 or BRCA2, where there's a risk for breast cancer as an adult. And that's partly because the Canadian guidelines, as mentioned by Amar et al. In the Journal of Medical Genetics, recommends against this. So we didn't actually ask that piece. Finally, of course, in any survey, you can look at those numbers. And if there's only 11 people that we had sent it out to, you may say, well, it's a small sample. We should probably be looking across the board so that we can get statistical significance. But ultimately, at the end of the day, there were actually only 11 Ontario genetic laboratories. And so having 9 out of the 11 does speak to a good proportion of those laboratories and what they're doing at this time. So an 82% response rate. And so in terms of conclusions, Ontario genetic laboratories tend to have similar reporting processes in terms of critical results, and you can see how it fluctuates dependent on whether it's a critical result or a routine result. And we found that both the type of cases, so whether it's prenatal or cancer, or perhaps the doctor actually asked it to be expedited, as well as the actual result itself may be considered more likely to be considered critical values. And certainly if we think about looking further, it would be nice to be able to then expand the study to other studies, other centers across Canada, for instance, to help really define critical values in a bit more detail. And so in terms of an impact statement from this particular study, we recognize that critical values in genetics hasn't really been clearly defined. And this current study is looking into that in further detail, both from a reporting process and actually what those critical values are. And we've highlighted those case types and also the pathogenicity of those results seem to help with the definition of a critical value. And so this particular study does define and help to define rather critical values within genetics and highlight some important results that may potentially be flagged for clinical care. And so as part of this particular workshop, what we wanted to do was have some discussion around perhaps proposed guidelines. So based on this type of survey, does it seem right for us to perhaps propose a guideline within genetics to say that if the patient type is as follows, so the ones that I've listed there, is that considered a good list in terms of patient types that might be a little bit more critical, where your turnaround times might be expedited? And within critical results then, thinking about both cytogenetics and molecular, would we again say, yes, of course, abnormal prenatal results should be expedited, but perhaps with the understanding that perhaps, especially in molecular, the unexpected results or the indeterminate results or the paternity potential results may actually be ones that actually need a different type of reporting process, perhaps not just a piece of paper in front of us or in the computer system, but perhaps a little bit more of a discussion as to what we think or what the current situation was. And finally, again, as a reporting process, perhaps in terms of insufficient and incorrectly labeled samples, perhaps we're not going to limit it to mailing because, again, snail mail takes maybe a week or two, and then it gets processed, et cetera, has to get to the right people. Whereas perhaps having at least 2 different ways of communicating critical results may be more important, just so that it gets flagged for the ordering provider. And so with that, I welcome any discussion. As you can see the little cartoon there, beautiful double helix here, but also the idea that there's a lot of results and information that comes out of genetic testing. And we really have to be able to pull out those ones that may be considered critical and may require a different reporting process. And so with that, I'd like to thank the co-authors of the paper, as well as the Quality Council, for their invaluable feedback, to the reviewer who gave some really amazing comments, and of course my laboratory colleagues who have participated in the survey. And I've included my email below. If the discussion in the chat takes more than the time that we have, I'm more than happy to answer any questions too. So thank you very much for your attention.
Thank you very much, Elaine. I think we will have the second presentation, then we'll have a discussion session. So I'm going to introduce next Dr. Felix Leung. I think many of you know in our biochemistry community Felix very well. Dr. Leung is currently a clinical biochemistry at Sinai Health System, and also assistant professor at the same department, laboratory medicine and pathobiology. He has interest in many areas, but particularly in quality assurance, in lab automation, in data analytics, and other areas. And he's been actually heading and helping with this quality sort of council activity around critical values. Actually also conducted a survey more focused on chemistry and hematology. So Felix, please go ahead.
Okay, great. Thank you for the introduction, Dr. Adeli. Can everyone see my screen? Hopefully it's the right screen. Okay, I'm going to zoom yes. So I'm going to follow up with Elaine's presentation on now talking about what we've done in looking at critical value practices and the actual values within the core laboratory. So more biochemistry, hematology, toxicology focus in terms of quantitative tests that the clinical lab performs. So just a brief introduction. Elaine already touched up on this, but if we go back to the core definition of what is a critical value, we look at it as something that represents a pathophysiological state at such variance with normal, so against what you would regularly expect in a healthy patient, that now this is life-threatening, and really it is a value for which something should be done promptly, and some corrective action could be taken to prevent any more serious injury to the patient. And so because of this, really we have seen that a critical values communication system is an integral and necessary component of any clinical laboratory. And that is pretty much universal and has found its way into most, if not all, accreditation requirements. If we look at what guidance is available, so there are organizations that have documents and guidelines on, what are things that you want to have within a critical value system. So for example, there are CLSI guidelines. The College of American Pathologists has looked at this extensively, both within their accreditation requirements and also surveys that they frequently do to their own American base. If we look at who we look for in terms of Ontario labs for guidance, really we are focusing on IQMH, now known as Accreditation Canada Diagnostics, as well as OAML, or the Ontario Association of Medical Laboratories. And if you look to see what guidance these two organizations provide for critical values, there is some, and they do provide details of basic requirements that you need, but I believe, and the council also believes, which is why we're looking at this, is that there are things that could still be fleshed out, even if we just look at what does the laboratory need to be responsible for within their whole critical values system. And if we look at sort of the basic framework of any critical value system, what we did in trying to develop a survey to see what practices are around the GTA is we basically broke it down into 3 aspects of a critical value communication system. So the first one would be establishing the actual criticals, and that could incorporate both the institution defining what they think a critical value is, beyond just that basic definition that I went over in that first slide, but also setting up what the actual values will be for the appropriate or relevant clinical laboratory tests. And then after you have that established, you want to have a system where you can appropriately flag and also communicate these criticals. So within the lab, how are critical results flagged for, let's say, mostly the MLTs who they're brought to the attention of, and they are the ones that typically initiate the communication. But as well, how does the communication process work? Who can you tell it to? And then also, if your initial communication attempts fail, does your lab have an escalation policy for if initial attempts fail? And then finally, after the critical value has been communicated or escalated, do you have processes in which you, number one, document what happened with the critical result? But in terms of a higher order, do you review and audit your critical values system periodically, whether it is looking at how efficient and how fast it is, your communication system, but as well, do you also audit your actual values periodically to see, are they still appropriate for your patient population and for your clinical services? And so what we're trying to achieve here within the LMP Quality Council is that we want to first collect data on what the current critical value practices are around the GTA hospitals and laboratories. And really that's just to get a sense of what quote unquote baseline we're working with, or what is the variation across all the different laboratories within the GTA region are, because this hasn't really been done in an official manner, at least in a while. And then once we collect that data, what we want to do is that we want to identify what commonalities there are in practices and values, and then what gaps there are, especially if we try to measure against literature guidance. And that can be a collection of the organizations that I mentioned already, such as CLSI and CAP, but as well if we can find any other survey literature that's out there that has looked at things like this in terms of what does the laboratory do in terms of their communication system, but as well, what are the actual values for core laboratory tests that most labs are reporting against for panic high or panic low or critically high or critically low. And then our hope is that we integrate all of this in terms of what we observe in GTA labs as well as best practices, and we're able to disseminate this data as consensus recommendations on how hospitals or laboratories should be managing critical values. So with that, we actually developed 2 surveys in the past year. So our first survey here, we surveyed actually 11 GTA hospitals and we had 7 respond. And this survey was focused solely on what their policies were. So essentially asking them for their SOP or any policy related to how a critical value is identified, established, communicated, documented, reviewed, etc. And what we found was that in general, all the hospitals that responded followed a generally consistent process. And this is not a surprise because this is a very universal and mandated requirement, at least by Accreditation Canada Diagnostics. So the general process was that you establish them with physicians in terms of the critical values. Results are flagged in some manner within the lab for MLT review. The lab staff is going to be the one that initiates the communication, and typically that will be for the most responsible clinical staff or team that is looking after that patient. You do require readback, so whoever is accepting that critical value needs to repeat back what you are telling them. You document it after that communication is done, and obviously there's an escalation policy if all of these initial attempts fail. And if we look into the actual data, so now I'm showing actual data from the survey. So again, we see a lot of consistencies within this general process. So for example, here we can see that consulting the clinicians is universal in terms of determining the critical values. And then you have a little bit of smattering of other sources such as literature, consensus values from peers, and maybe even empirical evidence-based. In terms of flagging, we see that there's a variety of manners in which the critical results are flagged, but they're always being flagged somehow. And it looks that most of the respondents are using some sort of IT manner, whether it is at the instrument level in terms of a middleware or their actual LIS system. And again, lab staff are always the one who initiates communication, which makes sense. And we have MLTs almost always initiating. And then we had a few centers that also have a call center as well, available to initiate the communication if, let's say, an MLT is not available. In terms of information communicated to the clinical staff and what information must be read back, we did see some consistent practices. And so, for example, if we look at what is communicated, almost always we're looking at the test value, patient first name, and patient last name. I think one of the labs may have not responded for this question, but this seemed to be pretty universal amongst the 6 labs that did respond to this question. But then we can see that there is a variety beyond what we feel are the most common pieces of information. So for example, patient identifier, units, what the actual critical value is, sample collection time, etc. And we see the same thing in terms of what we require the end user or whoever is receiving the critical result to read back. And so most often we want them to read back the value and the patient first name and last name. But there's variety in terms of, do we need them to tell us what the test is, what the units are, patient identifier, the name of the person reading back, etc. In terms of who can receive the result, again, it was very consistent that we always want the ordering physician or the on-call physician to and be able to receive the result. Nurses often could also receive the result as well. And then we can also see that there is a variety if these staff are not available, in terms of perhaps clerical staff can receive the result, or even if it's a regulated health professional within the circle of care. And so here's where we see a little bit of variety, despite very consistent practices amongst all the respondents. And then again, same thing in terms of the information that needs to be communicated and read back. We see the same thing in terms of what details are recorded once that communication is completed. So again, looking at the details of what the lab staff documents within their system of a critical value communication, it can be a variety in terms of all of these things that people, respondents noted that they will document. So in spite of all of these commonalities of a general process, we did find that within the general process, there were some of these institutional idiosyncrasies. And I'll go over a few of these as well, but in addition to what I showed in the previous slides of the variety, we also showed nuances in terms of some of these things that some of the respondents said that they do in terms of critical results. So for example, some labs reported that there are a maximum number of attempts to reach the clinical staff before the MLT invokes the escalation policy. We did see that there is variety in who can accept the critical result, what information is communicated, what's documented. And then another question that I'll go over is, are repeat critical values treated differently? So now I'm talking about if this is a critical value that is on a patient that already had a previous critical value, say within X time frame or X hours of a time frame. Another thing that we saw was that there were very inconsistent approaches to monitoring quality of their critical value system. And we had a few questions about this, and mostly it revolved around, is your lab monitoring the turnaround time goal for when a critical value is identified to when it is successfully communicated to the clinical staff, as well as does your lab engage in periodic review of your critical values? And I'll go over some of this, but we felt that because of these variations, this is probably where we can have the most impact in terms of what the Quality Council can do in integrating all of this information that we see, measuring against best practice, and then disseminating this data as consensus recommendations. So for example, some of these institutional idiosyncrasies, one of our questions was, do you have a maximum number of attempts to initiate communication before you invoke your escalation policy? So 2 out of the respondents said that yes, and that max attempts was 3 times for both labs. 3 labs said that there isn't a maximum number, but there is a maximum time frame. So we saw labs that said either 20 minutes from when the critical value is flagged or 30 minutes. And then we actually had 4 of the respondents saying that there is no maximum number of attempts, and we can assume that that means that they will keep trying until there is a successful communication. Another thing that we asked for was, do you repeat critical results before initiating communication? This is, again, a very common practice that we see, and it's always asked about in all of the, let's say, College of American Pathologists surveys, because it's so variable amongst laboratories. So for this one, we found that 2 respondents said that, yes, they always repeat critical results before initiating. 2 of the respondents said yes, but this is only for certain tests and instances, and they didn't provide further details. And then we actually have 3 of the respondents saying, no, we don't repeat critical results before initiating communication. So again, variable practices in regards to whether or not you repeat critical results. And then finally, in terms of the approaches to monitoring quality of your critical value system, so one of the things we asked for was, do you monitor turnaround time for receipt? 3 out of the respondents said that yes, they do monitor. It was a bit vague in terms of how they monitor. So one of the respondents said, we look to see that it is all within 20 minutes of a successful communication. Another respondent said, we look for 100% to be received successfully. And then another respondent said, yes, we monitor, but we don't monitor against any particular turnaround time goal. And surprisingly, we actually had the majority of respondents saying that they don't monitor the turnaround time for receipt of critical results. So again, another potential gap here, but certainly an inconsistent practice. And then finally, do you review critical results periodically? 4 of the respondents said that yes, they do it in cooperation with clinicians. 2 out of the respondents said that yes, they do it, but only internally within the lab staff. And then 1 respondent saying that no, they do not review critical results periodically. So again, variation here in variable practice, and certainly something that hopefully the Quality Council can come up with some consensus recommendations and or guidance for GTA hospitals and laboratories at least. So our second survey was now really asking the hospitals, essentially, can you give us a list of all of your critical values related to core laboratory tests, being anything within biochemistry or hematology or toxicology, if you have that as a separate division within your core laboratory. We managed to get a lot more information for this one, possibly because it was an easier survey to respond to. So we managed to get 15 GTA hospitals for all of their critical values. I'm not going to go over all of the data because we are releasing a report onto the Quality Council website soon with all of this data. But in summary, we saw a lot of variance between the laboratories, and this was expected. I want to be careful in this presentation that right now we are not commenting on whether or not an institution is using the quote unquote right critical value. We are just setting out to see what critical values are being used and what variance are we seeing. So we are not putting any type of objective assessment on whether or not these are appropriate critical thresholds to have. So I'll just use an example. And the first thing we looked at was obviously, given this test, how many of our respondents are reporting a either critically high or critically low value. And you can see that for what we grouped as blood gas or critical medicine type of test, it was quite common in that we expect these tests to almost always be offered by clinical laboratories. And if so, it seems like it was pretty consistent for most of the tests if they had a critical threshold in place. So for example, if you look across the blood gases, the electrolytes and extended electrolytes, you do see pretty consistent practices of actually having a threshold in place for a set test. And we did generally see that for the hematology and coagulation tests as well. So again, seeing APTT, fibrinogen, hemoglobin, leukocytes, neutrophils, pretty consistent practices of having an actual threshold in place for this test. For toxicology, it was a little bit more variable. Of course, the common thing we saw for toxicology is there were no critically low values because you don't expect to see these drugs in healthy patients. And really, we're looking at critically high values. Even though we didn't see, let's say, all the labs always reporting critically high values for all of the tests that we saw, something to note here is that it might be because the lab doesn't offer that particular test, and that's not something that we looked at, but that is something to keep in context when you're looking at how many labs are reporting critically high values for all of these said TDM/toxicology tests. Something we saw that thought was very variable was that outside of your typical blood gas and critical medicine type of tests, we also asked, do you have critical values for any of these more niche or outside biochemistry tests, and this was really variable. So you can see the smattering of tests and even tests in different types of sample types. So for example, total bilirubin, but total bilirubin in cord blood. You just see a variety of some institutions doing it, definitely not common practice, but this really could go down to there might be a particular patient population and or clinical service that warrants this type of critical. But this was generally variable, especially when we looked at these other biochemistry tests outside of blood gas and critical medicine type of tests. So beyond looking at the actual test, we obviously looked at, well, what are your values? How do those values variate or across the different institutions? But as well, if you're familiar with your critical value system, you know that for any test, you can set different critical thresholds depending on different patient demographics. So for example, age is a very common one. You may have something related to biological sex. So here I'm showing an example of when we looked at all of the glucose critical values that were reported by those 15 laboratories, number one, what do we see in terms of the variance in terms of both critically high glucose thresholds and critically low? So you can see that the low seems pretty consistent amongst all of the laboratories that reported it, but we see variable in terms of glucose panic or critically high thresholds. So you can see they can range from below 10 all the way up to 30 millimoles per liter. One of the things we also did is that within each test and each type of critical value, we took the median and set limits based on total allowable error from IQMH, just to see, is there a way to try to assess this variance based on, what we denote as the total allowable error. So that's what the red dotted lines are. Again, it is in no ways an objective assessment of, if you're outside this range, that means you have an inappropriate critical value. That is not what we're saying, but that's what those red lines represent. But even if you look across all of these variable values, we also saw a lot of variation in terms of how critical thresholds are stratified. So for glucose, we saw a smattering of institutions saying that they have different in terms of inpatient versus outpatient status. Certainly, there were a lot of age-related stratifications. We saw a lot of laboratories reporting different ones for neonates, different ones for pediatrics, different ones for adult samples, and then even down to sample type. If it's plasma versus whole blood, obviously whole blood being glucose on point of care devices and or blood gas analyzers. So again, a lot of variation even within one test that you would think should be quite common and consistent amongst laboratories. Another example of one where we actually did see quite good consistency are platelets. So we saw that for platelets, for both the critical high and critical low, it looks like most of the laboratories who responded are using very consistent values. Again, that doesn't mean that it is the appropriate value, but it does seem to mean that for platelets, there does seem to be some sort of consensus that all the laboratories are working with respect to their critical thresholds. And then I'm just showing here the stratifications that we saw reported. So there were age-related ones as well as disease type. So one respondent said that they have a different platelet critical threshold based on if they're an oncology patient. But despite that, we still see very consistent values. And so that's just a preview of the data. And again, this is all going to be available in the report that we're going to publish soon. Ultimately, what we want to convey is that despite seeing all of this variation, we are not at the point where we can answer the critical question, pun intended, which is what is the right critical value? And this is because if we hearken back to the definition of critical value, which is something that represents a life-threatening condition for which some sort of action needs to be taken, that really should go back to the clinicians who are the ones who eventually need to accept the critical value and do something about it. And because of that, it's very hard for us as laboratorians to answer this question appropriately, because whether or not there is consensus amongst laboratories of this critical value, until we engage our clinical colleagues and ask them, for this test, is this the level at which you will want to be immediately notified because you have an immediate action you need to take? We're unable to answer that. And really, this is going to be the next phase of what the LMP Quality Council wants to do in order to answer this question of what is the quote unquote right critical value. And so again, if I go back to what we're trying to accomplish, so really
Thank
we've
you,
already
Felix.
surveyed. Oh, sorry, I just have 2 more
Okay.
slides, Dr. Adeli. It's
Well,
almost done.
because
Yeah.
we want to leave some time for questions. Okay, thank you.
Yeah, so I mean, we're at this point, we've already collected the data. So now what we need to do is we need to measure against best practices and hopefully come up with consensus recommendations, which we feel confident we can do for the laboratory policies, but not so much for the right critical value yet. And so again, you'll see all of this data in much more detail with the report we will release. We will likely be able to disseminate consensus recommendations for what's needed within the policy, but our next phase is really to now engage with different clinical stakeholders to determine what the right critical values are. And so I just want to acknowledge everyone in the working group, as including Dr. Paul Yip, who's an honorary member, but Dr. Devor Brinks, Rania Ronaldo, and Daniel Barrio, LMP Quality Council, and then obviously all the laboratories who participated in the surveys. And with that, that is the end.
Okay, thanks again, both Felix and Elaine. Dr. Yip will actually coordinate, please.
Hi, so if you have any questions, you can speak, unmute yourself, or you can use the chat feature in the Zoom. And there are some compliments that I'd like to share. Joanna Ellis, thank you for all you do for this community, Elaine. I certainly echo that as well, seeing some of the work that's being done in the area of genetics and seeing how it has many similarities to the other laboratory disciplines. There is another comment from Mahmoud Arabi, genetics critical value study, very interesting. I think it would be great to define critical values in the context of genetics, since it may be different from other areas of lab medicine. And Elaine, you replied, thank you. Would you like to elaborate a bit more?
Yeah, so certainly I think about the idea of whether something is actionable or not. So for instance, if we think about a lactic acid level that's high, or if we're thinking about a troponin and we're thinking along the lines that somebody has a heart attack, there's immediate actions that would be provided based on those results. Whereas perhaps in genetics, the time frame for these results take a little bit longer, and maybe those actions aren't as immediate. So unless there's gene therapy that's actually proven to work really, really well, which at the moment beyond the eyes, there's really not, then perhaps it's a little bit harder in terms of couching that as considered a critical value. Having said that, again, with prenatal and oncology, you might be doing something different about it, whether you repeat the bone marrow, for instance, or if you do something in terms of pregnancy. So there may be some differences that you may do based on those results. So it's interesting. It's a different way to think about critical results for sure.
I agree, Elaine. There's definitely a lot of interesting things that came to mind throughout your presentation, and I was thinking about like how even the need for having a policy around this would have arisen. Perhaps it was through like physician feedback or possibly complaints or incidents, and it seems to have evolved in different ways in different places. And what sort of means do you have to kind of collect that information? Is it through like regular feedback surveys? Is it through like some other sort of metric or data keeping? How is it that you might actually get more information kind of like on a regular fashion to kind of inform what your process would need to do to serve your clients?
Yeah. certainly very interesting. And ultimately, I'm not the best person to ask that because I'm a clinician in medical genetics as opposed to Dr. Staropoulos, who does this on a regular basis. I know that, for instance, turnaround times have always been an issue, especially related to pregnancies. And so the feedback that we provide is pretty well clinician feedback back to the laboratories to say, hey, we really need this sample because we really need to get this result out for management decisions. And so it's typically been sort of a one-on-one. And we're very lucky in the genetics world that most people know each other and we work very closely with each other. Having said that, I think that there's more of a movement in the government now, knowing that a lot of our tests are quite expensive because we send a lot out of country for molecular testing especially, that there's now been a recognition that perhaps we can standardize our processes a little bit better. So I've been privileged to be selected as one of the individuals within an advisory committee that we're looking at various different ideas of both genetic testing and also the genetic test healthcare delivery services that will apply with that. So hopefully when we think about it on a provincial level, we may have more of those standards and be able to kind of feedback a little bit better that way.
That's great to hear. Are there any other questions?
I actually have a question for Elaine. Elaine, so it's mostly that comment you made about, I think, the Biochemical Genetics Center. I'm wondering, because at Sinai, we have our NICU and we refer out our biochemical genetic testing because it's typically very rare. I wonder, do these, let's say, genetic centers, whichever type of genetic discipline it is, when you serve as sort of a central hub for multiple places, is there periodic feedback or a way for all the different clients to basically get a sense of, do you need this test to be a critical value, or is there a way for them to even ask for that when it's technically not your institution because you're serving them as an external client?
Mhm. That's a very interesting question. And ultimately, when we think about metabolic and biochemical genetics, typically it's practiced in very specific centers. So Sick Kids Hospital and McMaster, for instance, will be the centers that will actually treat patients with metabolic and biochemical conditions. And then UHN as well, the adult center in Toronto will do so. So they have expertise within those areas to be able to figure out sort of, is this acylcarnitine profile normal or not normal? And when I am sending it from Children's Health Partners, it actually goes into laboratories in common, I think, that group. So it gets sent out and then it gets sent out from there. So sometimes I actually don't know whether it's being sent to McMaster or to Sick Kids. So it's a little bit harder for me to know. I have had instances though, where when I'm ordering these tests that I do get a response back from the clinician, either by email or telephone saying, hey, there's a result that I'd like to talk to you a little bit more about. So there is, again, that one-on-one, but not a formalized process per se.
Thank you. Are there any other questions? I do recognize that the workshop is supposed to end at 12:15, so perhaps we may need to end it here, and I'll turn it back to Dr. Adeli for closing remarks. Would that be okay?
Yeah, that sounds good. Thank you, Paul, and thank you, Felix and Elaine. I thought all three sessions have gone quite well. We had strong presentations followed by great discussion, and the whole idea was to inform the community of what's happening at the university and this quality council and get feedback. But not just today. Please do think about what you heard and email us or email all of the speakers, depending on the topic, and provide further comments. And if you'd like to get involved, please let us know. So I want to take this opportunity to thank everyone who helped organize, particularly Jenny Bozek at the university. I want to thank Dr. Rita Kandel, the chief of the department, who actually came up with the whole idea of doing this 3 years ago. And I'm happy that it has led to bringing many groups together across the city. The idea is to try to work together. I feel that we're part of the same family, lab community across the GTA, And the more we work together, the better we'll be able to assess how we do things, and we can learn from each other. And the idea is that the council will act as a catalyst, as a hub to bring people together. So thanks again. You will also see some documents being eventually published on the LMP website, and you might be contacted actually by each of these groups at some point to work with, to try to implement some of the recommendations. So the idea is to do the surveys, analyze the data, prepare guidelines, and then start working with each of the hospitals, of course, on a voluntary basis, to try to promote harmonization. So thanks again. Thanks, Paul, for coordinating. Thanks, Elaine, and thanks, Felix, and all other speakers. And thanks for all the participants. We had, I think, a great turnout, which is great. Thank you all. Bye.